Hello, how are you? It's morning here in Toronto, Canada, where I am. It's about 8 a.m. My son is about to go to camp upstairs, so sorry if you hear that. And when I Googled Canada and the United Kingdom, these were the first pictures that came up. Clearly, that's me right at the top of the CN Tower there. And you know, given what we all think about England here, clearly you all are in castles surrounded by Wuthering Heights moors. And one thing I do hope is bonding us this morning is having a cup of tea. I have a British family. My parents are both British, and so I don't have coffee in the morning. I have tea, and so today I actually pulled from one of my collections of British bird mugs and pulled the Dartford warbler because I'm pretty sure that's the most British thing. A cup of tea with the Dartford warbler on it, I think, was the most British thing I could pull out this morning. So basically hoping to treat this like we're all having a cup of tea, because I assume, based on my mother's tea drinking, that no matter what time it is there, you're all having a cup of tea. Priscilla, if you want to go to the next slide, that would be great. And what I'll do is like a very quick rundown of what I hope to cover today. Sometimes my timing is not what I had intended, so we'll either not quite get through it or I'll be done a bit earlier, but just basically a bit of background. Priscilla gave some. I'll try to give you a bit about who I am and why I ended up standing here and on your computer screen today. A little bit of context about specifically patient and public engagement, because I think a lot of you work in various sectors and work in communities in different ways. I'm going to kind of talk a little bit more specifically about kind of institutional patient and public engagement in the health system, which happens both happens all over the world, but that's where my sort of expertise is, and also where I think there's a specific sort of set of critical ideas that come up. A little bit about my lived experience with lived experience, because I like to get meta here, and I'm hoping there's something you can take away from all this, if not just listening to me speak. So we'll have a bit of that, and then hopefully my favorite part is always the questions and what you'd like to know. So if you could move to the next slide, Priscilla. And so basically they'll start with this: who am I and how did I get here? Well, Priscilla gave me a great sort of, she gave my bio, which gives you a lot of my background. But basically, I have a number of roles at any given time. I do a lot of different projects. I work for myself. So she mentioned all of the different sort of variety of health communications, or, I do copywriting, I do some podcasting now, but the majority of kind of what I consult on and what I do professionally does revolve around kind of strategy for and research about and critical analysis of patient and public and community engagement. So I think in England, that might be more referred to as PPI, or patient and public involvement. And so I'll kind of be using engagement, but probably you can think of it that way, of kind of what the organization involved does. And we'll talk about that a bit more later. If you could go to the next slide, Priscilla. So like I think a lot of people that actually work in this world of patient and public engagement, I actually came to this from my own patient experience. I sampled what I like to say, like a smorgasbord, a good medley of healthcare flavors, from emergency rooms, although I think that acronym, that should be AEs for you guys, but emergency rooms, multiple stints in acute care hospitals for orthopedic surgeries and recoveries. I've had, I've had inpatient mental health care. So sampled the mental health system as such that it is. I've had public and private care. I'll tell you which one I recommend more. And, I also have ongoing treatment for chronic issues that I have. I have some metabolic issues. I have obviously ongoing orthopedic stuff after the surgeries. So I feel like, I've had a nice circuitous journey through the system. And I like to say I've been through sort of basically all of the acronyms that exist. Although I know in good patient and public engagement work, we shouldn't be using acronyms, but I think you'll get what I mean. So if we could go to the next slide. All right. So throughout all this, what was going on? Well, at the time, I was actually, as I went through this, I was actually also kind of sporadically pursuing a degree in medical science. I thought, like many other people in undergrad, I was going to be a doctor, of course, because, it's either doctor, secretary, all of the things we assumed where there was sort of only three careers you could be. But I thought I'd be a doctor, or maybe get my PhD. I had very lofty ambitions. Oh, I think someone might not be on mute. Oh, there we go. But, and in the end, I guess I went to school long enough to maybe be like a neurosurgeon or something. But I managed to get my Bachelor of Medical Science. So I was learning about healthcare at the same time as I was experiencing. And I think what I really reflected on as I navigated my own patient journey as well as my education was, that so much of my care, which was focused on, this acute issues that I was having, these orthopedic issues or the metabolic issue I had, was certainly miraculous, and it sometimes blew my mind what they could do. And it was absolutely necessary, but it wasn't sufficient. It certainly wasn't sufficient for health. It was maybe sufficient for, fixing. And while I was grateful, I'm in Canada, like the UK, we have some world-class health systems. I was really shocked to learn how little of the things which were really affecting my health were not really even included, not only just included, but even referred to as I experienced the healthcare system. So, a lot of what was helping me function was how things were going with my family. How was I managing on a day-to-day basis? I had lost touch with my friends because I was in hospital all the time, and that had a profound impact on me. I couldn't have a job. There was no, reinforcement of my values, all of these things, which I had completely taken for granted before as a fairly quote unquote well person. And so this real visceral experience of how little the interactions with the healthcare system were my health. So if we could go to the next slide. That sort of interest in these broader contextual factors of health, and also, I think, in the end, realizing that I wasn't going to be a doctor, probably in part because I had met so many tired doctors and also realized I like to go to bed at a reasonable hour. I think I kind of embraced that maybe that real heavy duty medical career wasn't my job, but I loved medicine still. And I think also, to be fair, I was so immersed in my own health that the thought of doing something outside of my own experience was really tough to conceptualize. I think for a lot of people who are going through healthcare journeys, or their loved one is going through healthcare journeys, they do take up careers or passions or things within that realm, because the brain can't really say, put that aside now and go, do your job, when so much of your life is built around this. So when I learned about this idea of patient engagement, which is, like Priscilla said, about 15 years ago now, I really resonated with this idea of being what specifically was called a patient advisor. And I'd heard about patient advocates for diseases and disease-based organizations. I'd heard about harms to patients, where I'd read articles in the newspaper calling people to account. I'd seen that kind of advocacy a bit, but what I hadn't really heard about was this idea of embedding or integrating patients and their loved ones into the design of healthcare. And, I think it really jived with my sort of non-confrontational ways, my sort of apologetic, some might say passive-aggressive Canadian tendencies. And I really wanted to support positive change. It did feel sort of like rainbows and unicorns. Wow, here is a way where we can all collaborate together and bring awareness to what only patients and their families can see, right? And so again, I don't mean that this isn't supposed to be like a derogatory thing. I think it's kind of a natural reaction for a lot of people when they go through a significant health journey. So if we could go to the next slide. Great. And I don't think my want to get involved or to bring a patient experience was completely driven by just idealism or self-centeredness, though I think that was part of it. There was real logic here. And I think at the time, of course, many have been calling and screaming about social determinants of health for many years. But at the time, it was becoming much more aware, sort of talked about in the public, and also there was a lot more sort of specific evidence coming out for how much of health is created in the social determinants. So things like where you live, sociocultural, demographics, yes, behaviors, but all of these things outside of what medical care was doing. And that really fascinated me. I think when I looked at this acute care system, which was focused and built around, I feel like really clearly quality evidence, which is based on or evidence-based medicine, randomized control trials, clinical trials, and expertise. It's obviously so key, particularly when solving problems like how do we, cure certain cancers and do these things. But when I looked at a healthcare system, when I thought about a healthcare system, it was clear that sort of evidence and that sort of acute care approach was not going to be sufficient to create a sustainable and particularly an equitable and effective system. And understanding how people's experiences interacted with that system, and how we could support people in all their complex ways was going to be essential. Now, for me, as someone who was really interested in medicine, but also maybe being the daughter, my dad's a philosopher of science. So, I thought a bit based on his teachings about what is science? How does that work? What makes knowledge and what makes something valid knowledge? And so how we were going to integrate people's experiences, which had always been kind of looked down upon as anecdotal evidence. How are we going to integrate that into evidence-based medicine in a systematic, fair way? Well, I found this really exciting and really, really intriguing. Next slide. And I think, oh yeah, great. And I think, the other thing that was happening at the same time was, technology was allowing people to really have a voice individually. You didn't have to just belong to an advocacy organization to kind of get some balls rolling. You could go and have a social media account. People were starting, even back then, podcasts. People were doing YouTubes about their experiences and calling for different changes. Especially there was caregiver movements that had started. This was really beyond traditional advocacy groups, and it wasn't necessarily political always. It was much more about people having a voice. And that also was really exciting, right? It was like, wow, people who haven't been able to be heard were now having a place or a forums to take their experience. Next slide. Now, the healthcare system was not noticing, and I mean, I don't mean to presume or say that this was without precedent. There's a huge history in health, of course, of involvement of people sharing their experiences, but it was much more advocacy based, and it did tend to be more in mental health and in certain sectors. And again, it wasn't usually from the institution. It tended to be from push from communities or advocacy. But now I was seeing the actual institutions and this was sort of all over the world, really embracing this idea of patient-centeredness, hearing from patients, making sure that individuals were having the best care. And, I love this. Patient engagement is the blockbuster drug of the century. Now, that's from the US. So obviously patient engagement has a slightly different tone there because, it's not a public system. And so the idea of engaging patients has a bit of a different incentive. But I think it captures this idea that it was going to fix a lot of things if we could partner and engage with patients throughout the healthcare system to help us design, to help us do these things. And I love this in the corner with I don't know if this is the Sistine Chapel or ET, what's going on here, but it was also very, it was painted in a very, very sort of ideal way, very romanticized way. And it was enticing for sure. Next slide. Thanks. And it wasn't just happening, in rhetorical or through talking or through exciting headlines. It was being mandated that patients and caregivers and not so much the word the public was much less used, I think, in Canada, but that they were going to be embedded in decision-making levels, in integral positions throughout various sectors of health. And so this is an example that was taken from, back, I've had this slide for quite a while. So, when the individual healthcare organizations started to be mandated to develop patient and family advisory councils. So as opposed to feeling like there was want from the community or there was a specific need, you had to have one of these built in. We called them PFACs for short here, because like I said, we love a good acronym. And not just in those individual, this sort of demands was coming from the government. And the government was saying, that we need to engage with patients and families at all levels of healthcare, and that they were committed to doing that. Exactly how, at the time for sure was TBD, but I think one of the biggest structural components of this world of patient and public engagement happened at the research level with the National Strategy for Patient-Oriented Research. This actually was developed when I started in patient engagement, and I sat at a few tables even where they were discussing, how is this going to work? How are we going to have a body that was focused on what we called partnering with patients in research? So no more were patients going to be just subjects. We were going to have patients sharing their experiences within research. It's very exciting, but it was going to be a very, I think everyone understood, like complex and tricky to do, to put into action. But we were going to do it, and we were going to have it mandated within certain funding areas of federal healthcare funding. Next slide. Oh, thank you. And certainly we were not the first to do this. It was a global thing, and I'd say the UK is still seen as one of the first to kind of embrace this idea of public involvement in health research and more broadly in health. So in 1996, Involve was created to bring the public into health research, and much of CIHR's, the Canadian Health Research Federation work was actually drew on a lot of the work of the UK. In the States, there was a center which was a little less about sort of partnering with patients, I would say, but certainly involving patients in developing research questions specifically around effectiveness sort of research. And like I said, in 2011, Canada created the Strategy for Patient-Oriented Research, and the grant applications had to have patient engagement plan, and there had to be patient representation on the team. The trickiness of that patient representation, I think, is where it starts to get interesting. Okay, next slide. And I was here for it. Let me tell you, I wanted to do all the involvement. I was what, as Patricia said in my bio, an eager patient partner. The excitement to actually have sort of meaningful change as it was spoken to me was great. And this is like a quilt of different options we have here, but these are some of the ones that I think even to this day, probably patient partners or people who get engaged in health often end up kind of joining, whether it's a patient council for something, a government committee. Sometimes I was on like a board or a working group or a steering committee as a patient representative, quality improvement. And how did I get involved in all this? Well, I'd say at the beginning, there was a little bit of like, can I come to your conference and ask a question about like, where are patients in this? But, as soon as I did one, I was asked to do another. And then I was asked to do another. And then somebody said, well, I saw you speak at that thing, so could you come and do this thing? And as much as I'd like to think that was because of my qualities of, the talk I gave or something, a lot of it was to do with the accessibility of me. Okay, we've seen this person. This is a safe person to have at the event. This is also someone who, people didn't know what was the appropriate way to go and find patients or to involve patients. I was sort of a non-confrontational, eager, pretty educated person who was available in the middle of the day. It's kind of ideal. And And I think, you know, at some of these things, there were times when I really did shift things. I felt that, you know, my comments would get into the report out of something, or you know, some sort of agenda would change. But really, you know, most of the time, the impact I was having was probably on the wording of the document being a little bit more what would be called patient-centered, or maybe you know, the change to a visual in a patient brochure, things like that. I also did a lot of telling my patient story, so much to the point that my patient story almost felt like this weird this weird made up thing in my head, because I'd said it so many times. It was almost disconnected from from me. But it got a lot of resonance from many people, and I think I heard a lot of that was very insightful. And I mean, who could resist, right? Now, if we go to the next slide, all of the while, a whole industry was kind of being built to kind of figure out how to do this, drawing on, I would say, a lot of historical or sort of other work in social sciences and stuff that was really about active participatory research and things. We were drawing on a lot of that. We were really trying to figure out how to do this kind of institutional engagement, which was mandated in this way, and which had to be played out by institutions hiring people, getting people to follow guidelines, to be accredited. They were being written, and more mandates were coming. And I think people were really struggling to figure out what is the how. I think at this point, people were assured that they knew that they wanted to and really believed in patient and public engagement, but the how was inevitably very complex. Hence this plethora of frameworks. And sometimes I used to feel like, when in doubt, make a framework, or when in doubt, make a plan. It felt like everywhere I worked had their own version of a sort of similar-ish version of something. We didn't do a lot of like going and just finding one and then implementing it and seeing if it worked, because I think there was this real want to produce material and be seen to be producing. Next slide, please. And I think, I mean, it's, as we were just saying, memory is a bit weird. I think it was around here, around when this sort of time frame, that things just stopped adding up quite as neatly. I think originally I had really understood the logic behind the involvement of patients and the public. Like I said, I completely felt that there was a need and a necessity to understand experience and understand the complexity of people's lives, understand the power dynamics that were going on, that were affecting people's health. That knowledge was absolutely essential. It was the how it was manifesting that was making me a little bit more skeptical and a little bit more uncomfortable, because the ideals that I saw being set up for what this was supposed to accomplish, like I think originally it was like, yes, I'd like us to understand these things better. I'd like us to partner in order to make changes. But the idea is that this was going to create health equity, or by just virtue of engaging with patients, we were going to make substantial structural changes in institutions, which still remained institutions as they were. And I became a lot more curious and eager to participate in more critical dialogue, which really felt difficult to find, because the questioning of patient partnership or involving people with lived experience really did feel, well, kind of unfair, because that's not quite what I wanted to do. But also for the people doing it, they certainly already felt like it was difficult to kind of question whether they should put a patient partner on their team, let alone question the whole enterprise of this. And so the only conversations I had were like in the corner of a conference here or there, or sometimes over coffee. And we'd be like, you know, that did seem a bit weird that they had to have a patient partner, but it was this one, like these more nuanced aspects of the whole thing. And that's where I want to get into it in this next section a little bit, which is just a few of the trickier aspects of patient and public engagement. These aren't just my ideas, but I'm going to tell it a little bit more about how they unfolded to me. And again, this is by no means a comprehensive list of all of the tricky issues in patient engagement, but I raise them with the hope that maybe some of you will resonate, even whatever sector you're in, and maybe that we can remind each other about how important it is to say some of these things out loud and to struggle through them, but together. So if we could go to the next slide. I think one of the most obvious ones, and the one that's probably the most talked about, is this idea of like who is a patient partner and who gets involved in that little quilt of opportunities there. And so when I think back to those events and think about what they required of me, you know, to be sort of confident and motivated enough to go, for one, and sit at a table or speak in front of people. Particularly those people were a bunch of academics and clinicians who really, probably had not done a lot of this kind of relationship building, sort of like focus on experiential knowledge, that sort of thing. Most of them didn't have much experience with that. And as well, you know, here I was to help with their projects, which, you know, they owned. And at the beginning, it was mostly volunteer. So I was usually doing it for free. It wasn't until much later that, you know, enough pushback came where about payment. Mostly the things were in the middle of the day. And mostly it was like just me. Maybe there was one other person. So, you know, I really like this framing, which I took from Holmes, which usually when I would read about the problems that we have in engaging with quote unquote diverse patients, how do we reach the hard to reach, all of those things, it's framed as if like people are out there, they're hard to reach. How do we get to them? What are the recruitment methods we need to do? As opposed to kind of looking back at the institutional practices and kind of wonder who would want to do this? Like, which people are going to come regardless of how hard I try to recruit? The kind of engagement envisioned by people, you know, it requires a demanding set of attributes. And I don't know if it's also the way that people want or are already engaging. So next slide. And so I can tell you anecdotally who I saw at these other events, who I knew, who I loved. To be honest, I met so many bright, interesting, passionate people in my work in patient engagement. I will say passionate, engaged, and mostly female, mostly white, and mostly over the age of 45, and many of whom were retired. And again, that's not derogatory. That's just who could come, who was interested. And also, we kept being invited because once you started being seen at events, you would get invited to other ones. Now, this bears out beyond the anecdote. Last year, there was, or I guess it was a few years ago, a great research team did some work into who are patient partners in the healthcare system in Canada. And this is sort of what they found. As you can see, basically over 75% was the type of person I had mentioned. And they all had a desire to improve the healthcare system and felt enthusiastic and valued. I wondered how those percentages would have been different if it were a different set of people, how enthusiastic they would have been, or how valued they would have felt, or what other experiences they would have had. And, you know, it came to be kind of a joke that we, and I think there's even a paper written about it, we call ourselves the usual suspects. And we would sort of joke like, oh, the usual suspects, or, oh, I bet I can guess who's going to do a talk for that one. And, you know, it was funny, but in the scheme of things, it does give you pause. Next slide. And the other thing I really started to question and shift on was this idea that this very exciting idea that I could be a patient advisor that was collaborative and working together was instead of being an advocate. And, you know, these pictures came up when I looked at patient advisor. This was the first picture. And to be fair, I didn't put patient advocate, but this was advocate. I put up the first picture. This is the first picture. And I thought, well, isn't that telling of how we view these two things differently? And I'm a bit embarrassed to say that this is actually, this quotes underneath is taken from some training that I used to do with a colleague of mine, where we would help new patient partners understand, you know, how to do patient partnership, what to expect. And you'll notice the language about why we should be an advisor and not an advocate. Because an advocate is someone who has a passion for a certain agenda and his only focus is to push that agenda, and they don't want to work with others. Yet, when you think about it, as well as if you dig into the literature, because I have a little bit, which one leads to more actual system change? Which one leads to lots of probably change of maybe the agenda for a grant proposal, or maybe some pictures and things, which all actually do have effects. But if we were saying this was going to cause system change, well, I know which one would suit a system that doesn't want to change. So next slide. And if I was there to advise and be an advisor, what was I representing? The thing about advocacy was that advocacy usually stemmed from a specific place of political movement or a knowledge of a community who were asking for something specific. So what they were representing and the group they were representing was a bit more clear. When I was there, I was representing me. And as much as I was told over and over that I was not there to represent all patients, what I was saying was being taken and put into the wording of a document, or thought of as kind of prototypical, else what were they going to do with it? And if they were going to extrapolate from my experience and the experience of many people around me who were like me, how were we going to change the system? You know, this really started to kind of scare me. And the picture I almost put here instead was of a red sports car, because I feel like this is where I was like, who am I? What am I doing with my life? I felt like I believed in this, and now I'm questioning it. And, you know, I grappled with some things, and I basically decided to just delve into like learning more about other advocacy, about different kinds of engagement, about what came before. And that was exciting and an opportunity. But again, it really is, I think, one of the key factors here is that if we were going to triage who we were hearing from and what kinds of knowledge we were bringing forward, if we were going to triage it based on what things are an emergency in our healthcare system, I don't think I would be, like I said, I think I had a valid experience and probably informative in some ways. But if we were going to really focus in, where should we be focusing our attention when it comes to people's experiences? Next slide. And so the thing about institutional engagement is that, you know, a lot of the ideals that I was encountering, like I said, changing power, having shared power at the table, or having people feel empowered. There was a lot about power, which was interesting given the advisor versus advocate thing. Well, but the ideals I'd read in references and frameworks about mutual respect and co-design, often terms taken from actually historical movements around participatory action and stuff. These were very lofty ideals. And when we tried to squish them into an institutional setting, we pretty inevitably came up against barriers. It wasn't just me noticing this. I mean, even the researchers I'd worked with would talk about the loopholes that they would look for to, you know, pay a patient fairly, and budgets and timeframes would be, you know, a few months, and yet the best practices would talk about building relationships and going into communities to meet people and develop relationships so that people could feel safe to come into the institution. And I would think, how are people supposed to do this in the time frame that is here? As well, how is a patient partner supposed to be on a grant proposal who, A, is ideally supposed to not be one of the usual suspects, and as well is supposed to have built a relationship with the researchers, is supposed to have a certain amount of training so that they could become a patient partner. And yet this research team has never had any funding yet, has no money to pay this person until they get the grant. You know, the backwardsness and the barriers felt like they were at every turn. Payroll structures are certainly not set up to pay people fairly. They often would talk about how paying engaged patients was really going to change the power dynamics. And I think there's some truth to that, although I think that it can be difficult. There's other difficulties, but even when you did go to pay, many people who would be part of some of the research teams would, if they were trying to pay through regular structures, would end up having clawbacks from social programs. We would look for ways to give bursaries, but then often I would, be helping a research team do engagement, and we would meet the maximum for what you could give as a bursary so quickly before we'd have to tax, provide, get social insurance numbers, that we would have to stop, or we'd have to find other ways. So it was getting clearer and clearer that the ideals and the things that were laid out were not fitting neatly into this institution. As well, it was starting to feel like the process of doing it was so much of the point. Every agency I work with, every group I work with had to be seen to be doing engagement. You had to be showing you were doing it. You had to be evaluating it. You had to have everybody feel that the engagement was going well. And I don't think that's wrong. But that became the job on groups I would facilitate, consult with and help facilitate the engagement. I would say like 80% of my work was just making sure everybody felt like it was going well, checking in. And again, that comes with engaging people with lived experience amongst people who have expertise and are just speaking from a professional lens, because of course those people need special support. Of course you can't have regular just sending an email with the team agenda and not checking in and that makes complete sense. But is the institution really set up to do that? It's another question. All right, next slide. And so this idea that this institutional engagement, this sort of moving things through the process of engagement through, the guidebooks and engaging and then learning from, and that this was the only way we were going to understand what patients and the public and human beings needed, started to feel less obvious. Basically, everything I was doing was what you would call sort of top-down engagement, out of necessity. The funding, the money was all from the institution, the people, the staff. That's where they were. Even if we wanted to have community-led dialogue, it had to start still with the institution. But what of great ground-up engagement? There's so much that's already happening in communities that are self-defining, as opposed to us saying like, well, we need someone from this community, and there have been so many calls to action that have been really clearly stated for years sometimes. I think my naivete that there was so much we didn't know about what patients want at the beginning, or I shouldn't even say what patients want, how the healthcare system needed to change. Well, that felt again convenient on the part of the healthcare system. I'll never forget going to one council meeting, or a meeting where we were working with the organization, I think, to maybe recruit people to a co-design session or something. And they were asking questions, and one woman just goes, "How many times do I have to tell you that it sucks to be poor?" And I remember being like, yeah, we're asking people to do a lot of questions, go through a lot of hoops, just to say the thing that some groups have been saying for a long time. Next slide. And it's not benign. Throughout all this, I sort of lent on the feeling that we're really learning as we go. And I don't think that's wrong. I think learning healthcare systems is great. Like, we shouldn't totally be afraid of failure, and we shouldn't be. But it did feel like, yes, we can do that if it's maybe someone like me who had social supports outside, who had the ability and maybe knowledge base to say like no to things, to not fear certain pushback or things taken away if I said no. But there's a lot of risk to doing this wrong. If you're a partner and not a subject, we don't have accepted ethical frameworks around how to protect your rights. Sharing your patient experience. I mean, for me, it made me feel vulnerable. I can't imagine for people who have a very different experience to me. The exacerbation of distrust in the system, I definitely saw in people, particularly who were asked to come in to kind of fill a certain role as someone with a very experience from a different racial group, or to be seen from a specific community. And they would come in and things wouldn't fit necessarily for them, or they would not be followed up with, or things would happen where they were left further disenfranchised and felt harmed by this system itself. And, more broadly, as I spoke about before, when I thought about extrapolating from me, this idea of sort of reestablishing barriers and inequities, and there's some great work written on this, and as well about the kind of displacement of community-led advocacy. This idea that there are repercussions to this, and so that we should tread thoughtfully and reflectively as we go and look back. And I guess that takes me to kind of the final part, if you want to go to the last slide, or the almost last slide. It's the sort of, so great, now what? Like, it all sounded sort of hopeless, and I don't mean that. I'm actually a very optimistic person, generally, even at 8 a.m. I don't feel like all is lost. I still work in engagement, and I work with teams that are fantastic and are so thoughtful about how they can flip things around in these institutions. How can they like lend researchers to a community instead of like starting from a point of their grant proposal? But you know what? Those groups by nature have to have funding to do that, have to have a certain structure in place, have to be basically dedicating their lives to it. And so, I mean, I think there's certain hope for what we can do, but I also think it's okay to accept the limitations. It's okay to have patient engagement, to do the things that patient engagement can do, and to have other methods of engaging, other work and other knowledge bases inform us about healthcare change. Now, I don't think anyone's debating that, but I think it was something that really struck me along the way. And if I were to leave anything with you in the end, and I mean, I've had a lot of group therapy. I've had a lot of therapy in my life, but including group therapy. And in group therapy, we're always told, don't give people advice. Just reflect on your own experience and let them take something away if they want, kind of. So that's what I sort of tried to do today. And I hope that what I showed you was how much critical reflection shifted my thinking, connected me with other people, helped me learn about things that happened before me and are happening around me, and how stopping with just the doing and the assuming really opened me up to, I think, a lot more joy in my career and a lot more potential for hopefully doing good work in the future. Next slide. With that in mind, total shameless self-promotion, but I think a great thing for what happened for me, which was fantastic, was, I met someone who had these kind of critical interests too, and we started this podcast together to look at some of these issues that I touched on today, and so many more that I've now been exposed to by talking to these bright people. So much of these episodes and the other like 40 or whatever that we have informed my thinking and completely given me like moments along the way. And there's a few here, we touch on the vagueness of language and how that affects how that serves institutions in what we do, and how using terms like reaching the hard to reach or marginalized get used without actual meaning in so many cases. We talked to people about flipping the script on narratives about engagement in Black communities, particularly during COVID, and how much already happens in communities, which is completely outside of institutional practices, and yet people feel they have to join these institutional practices if they are going to have their knowledge legitimized. And so many more here. I invite you to listen, if only to start your curious inquiry. I also invite you to hopefully follow up with us or me, or ask questions and connect with others around some of these issues. And that's it. Thank you so much. Last slide, which is just sort of like a closer, which is basically sort of my favorite part. We have about 10 minutes. I'd love to know, how does this relate to what you're working on? What questions do you have? What did I get wrong? What do you totally disagree with? That's often when I learn the most. So actually, final last slide, there's one that just got my email on it there if you want. So thank you so much. And yeah, I'll just open it up.
I will just go through it now. We had one hand up. Don't know if you put your hand up. Maybe you can just unmute your mics if you can, and just ask your questions.
Yeah, I just want to kind of break the wall of silence, because I just want to say thank you. I honestly didn't know what to expect from the session, but it just gave me so much kind of food for thought. I don't actually know where to start. I think I just need to have a moment to kind of reflect. But just to say thank you, just to kind of share your story, your vulnerability, the kind of critical assessment that you do, it kind of just rang so true with myself and how I kind of sometimes start something and then go back and think, actually, you start picking stuff apart and start thinking and questioning everything. And, what am I doing here in the first place? And I know that I started with great motivation, but actually there's a lot to unpick. And, you're human. And so I think just admitting that there's so much kind of layers to this, and maybe we do need to kind of rip up the book and start again in some instances, and rethink, and particularly about the systems. It's more about the systems have to change, as opposed to thinking that we'll speak to the community, we'll get our evidence, and then we can go off and how great are we type thing. So yeah, just really say thank you, and a lot to think about. Thank you so much.
Oh, thank you, Natalie. I can't tell you how touched I was. I was quite anxious going in. I didn't know who was going to be here or what people were interested in. And I definitely still feel vulnerable sharing any criticisms, and particularly from my vantage point and those things. But if I was just thinking as you said that, you might be really interested in that episode on vagueness in language, because they talk about institutional ethnography. That comes up in a few of our episodes. But this idea of like, we're doing all of this research on patients and what they want, and turning the lens back to the institution is an interesting idea that's been around for ages, but doesn't get talked about as much, certainly in this realm. So, but thank you. I sort of feel like my blood pressure went down a lot having heard that.
No, thanks a lot, and I'll definitely will be listening in. Thank you.
Great, thank you.
Anyone else? Eleanor's just put in the chat. Absolutely, really insightful presentation, and so much to go away and process, to think about. So thank you.